I think we're ready to reconvene. It was a great networking activity out there, and I really appreciate the fact that people were spending time to talk and share ideas. We're moving along to our second panel now. This one is going to be more of a discussion group, dialoguing, I think, and a little less formal presentation with PowerPoints and that sort of thing. And to lead us through this is Linda Rouse O'Neill. And Linda, I'm going to turn it over to you as the VP of Government Affairs at the Health Industry Distributors Group.
All right, thank you. Good morning, everybody. Everybody got up, stretched their legs, and had some good networking. As you said, I'm here with the Health Industry Distributors Association. So my members are medical surgical distributors. We talked a lot about pharma earlier, but as was mentioned, we are going to get to devices. But the point of this panel, and I'm really thrilled and privileged to be able to be the moderator for this one, is really going to focus a little bit more on how these shortages that we've been talking about really impact providers and the care that they're providing to their patients. So I know we all tend to get very quickly into solutions, and that's come up a couple times already this morning, which is really more the focus, as a reminder, tomorrow, even though it's hard to not plant some seeds for tomorrow. But this is really to remind us about why we're all here, and it's about providing the care to the patients who are in need, who are depending on these products that we all make, distribute, or utilize in how we care for our patients. So with that, there are full bios of our wonderful panel in your packet, so I'm not going to read every single accolade about them, or it's going to take the entire time of the panel that we've got. But with us today, we've got Steve Krug, who's the head of Pediatric Emergency Medicine at Northwestern University. We've got Mike Bowen, who is with the Secure Mask Supply Association and is the EVP of Prestige Ameritech, one of the only surgical mask manufacturer, correct? Left in the U.S. And then he's going to be followed by Alan Veda, who's with the EVP of the Institute for Safe Medication Practices. We've got Bonnie Levin, who's the Corporate Assistant Vice President for Pharmacy Services at MedStar Health. And then James Robinson, who's the Assistant Chief of Paramedic Division at Denver Health Emergency Medical Services. And as what's mentioned, these folks are not going to stand up and do PowerPoint presentations. They're going to sit, they're going to be comfortable. I'm going to tee up the first question, and they've got stories to start sharing and moving down in the order that they're sitting. And I've got a couple other questions to tee up to keep going down and building on that. However, it's going to then become a very, hopefully, free-flowing conversation where they're going to interact with each other and build off of what each other's saying, and then we'll have opportunity for Q&A from you all. So, with that, if everybody's comfortable, we're going to talk about first is how medical supply shortages during disasters affect them in their organizations. And each one of them's already gotten, from our prep call, a little bit of a story. You're going to hear a lot about H1N1, and you're going to hear a lot about Ebola, and you're going to hear a little bit about the opioid crisis and fentanyl. And so with that, I am going to turn it over to Steve to start first. So Steve.
Hi, good morning, and thanks to the Planning Committee and to Admiral Vanderhagen for the opportunity to talk with you guys today. I'm going to tell you two stories. The first is from 2009, the H1N1 outbreak. I work at a children's hospital, and as you may recall, H1N1 was somewhat selective in the population that it affected with severe illness. But of course, there were so many other patients with minor illnesses. And I work in an emergency department, and we were sort of the Band-Aid in the overflow because the number of patients exceeded the capacity of the local public health clinics, federally qualified health centers, physicians' offices, et cetera. We ran out of a lot of things during H1N1. One of them was people, and we actually went rogue a bit in terms of telling folks, well, the moment you feel better, please come back to work. Specifically, we about 2 weeks into the event, ran out of N95 masks. We just didn't have any more. We had a few left, but we were saving them for the sickest patients in the sickest places, essentially our intensive care units. So we were forced to utilize other barriers and excessive hand washing and whatnot. There was also a shortage of the influenza testing kit. Which we were happy to manage because we adopted the policy, if it looks like the flu and it smells like the flu, it's probably the flu, so we should treat you if you deserve to or you warrant treatment. Unfortunately, families and providers in the community didn't quite see it that way, and so we saw hundreds of patients sent to us for flu testing. The other thing that patients got sent to us for was for the Tamiflu, in particular the liquid version, because that was in a severe short supply. Also, even the solid tablets ran out in certain areas in our region. And the word on the street was, well, go to the hospital because the hospital has it. So that was tremendously difficult for us. On the oral preparation, again, speaking as a pediatrician, it makes sense that the kids aren't going to swallow the pills. And while there were reasonably well-written instructions in a variety of languages to assist families in constituting a liquid preparation from the pills, let's just say if you're taking care of patients with low health literacy, the instructions don't work. So that's a problem. So there were a lot of patients who didn't get it because the families just couldn't manage that. Let's fast forward to the Ebola outbreak in 2014. The difference here is that this was a really high consequence disease. Fortunately, we never actually cared for a patient with Ebola, but through some interactions with the CDC, we became a local pediatric treatment center. Particularly when it became clear that the treatment center actually couldn't care for kids. We did a lot of talking institutionally. We got our staff to commit to doing this. Our plan was to prepare about 75% of the ED staff and a core group of ICU staff, since that's where the patients would go once they once they were cared for in the emergency department. It was not easy to get staff to commit to that, and it became even more difficult when it became apparent to the staff that we actually didn't have adequate supplies to care for these patients. We had a limited number of PPE suits. If I was to stand up, you'll notice that I'm rather large, and there were no suits for my size, which meant I didn't get to practice, but of course, as the leader, I'm supposed to do this. We eventually got the larger suits. But in the end, that contributed to some significant distress amongst the staff that was also essentially already terrified about having to do this. And it made our efforts to prepare it as an institution exceedingly difficult. We pulled it off. We eventually got some PPE through local sharing, and the CDC, I think, stepped up nationwide to provide more supplies. But had we actually gotten an Ebola patient, I'm not sure we would have been prepared to protect our staff because of our supply level at that point in time.
Okay, I think that is going to tee up Mike.
Good morning. I'm very happy to be here. I am the spokesperson for the Secure Mask Supply Association, which is a group of 4 domestic mask suppliers. They're trying to make America's hospitals and medical community aware that 90% of the mask supply is reliant on foreign health officials. Masks don't traditionally have shortages during peacetime. It's during flu and pandemics that it's the reason he couldn't get N95s. So we don't worry about masks during peacetime. Nobody does. Nobody thinks about it. So it's kind of taken for granted, even though it's only a $150 million market. I'm also the vice president of Prestige Ameritech, which is the largest surgical mask maker in the United States. We're in Texas. And in 2009, we weren't very well known. If you would have Googled Prestige Ameritech at the start of H1N1, you would have gotten my business partner's son's MySpace account, not Facebook, MySpace. And shortly after that, shortly after it struck, the Fort Worth Star-Telegram did a story on how we were ramping up to help hospitals. The story was picked up by other local television and national television news. We were on Fox News with Neil Cavuto. My business partner is in a studio in Irving, Texas, listening on an earphone and looking at the camera, and he hears Neil Cavuto say, "Thank you, Mayor Giuliani," and now to Dan Reese in Fort Worth to talk about face masks. It was crazy. Our phones were ringing off the wall. And the government of Mexico called. They wanted all the masks we could make. America's hospitals were calling. They couldn't get their imported masks. And they wanted all of our masks. So we had a choice to make, and the choice we made was to help America's hospitals. So we hired 150 people. We built several new mask machines. We bought a larger facility. And all the time asking these hospitals, telling these hospitals, hey guys, we're spending millions of dollars. Please stay with us after this is over. Oh yeah, we will. Well, they didn't. We also helped the U.S. government. 4 agencies of the U.S. government who never buy U.S. masks started needing U.S.-made masks. We made them by the millions, and we haven't heard from them since. The aftermath was that the 150 people we hired to keep the U.S. mask supply going were rewarded with pink slips. All of those people got laid off because right after, at 4:30 one day when somebody said, pandemic's over, everybody stop ordering masks, the orders quit. And not only did the orders quit, there was a year's worth of glut in the marketplace. So we, besides laying off 150 people, we nearly went out of business. We had to raise about $1 million to survive this. So gearing up for a pandemic, a lot of people think, oh, you're in the mask business, it's flu season, you're really happy. No, please don't. We want peacetime. We want regular, level-loaded orders. Nobody wins in a pandemic, and it can be pretty rough, as it was with us.
Okay, great. Before we shift to Alan, one thing you've heard from the first 2 speakers is really more on those products during times of Ebola and a little bit on H1N1 and the panic and everybody wanting to be protected and the demand, which we talked a little bit about economics, right? On the first panel, the demand goes up, and then this time the market tried to respond, and then the demand goes away because the panic's over. And so I think that's things to keep in mind on behavior of providers and patients and the communities at large during an event, regardless of what it is, as well as then on, since I represent distributors as well, when you see the supply chain try to shift and meet that demand, and then that demand goes away. And I know that I heard from some of our distributor members during H1N1, the opposite, the issues. They had N95 masks for years afterwards that they could not get rid of because there was a huge surge in demand during H1N1. It went away. And you don't need N95 masks for, in your regular physician office for all those types of, patient encounters. And the demand went away, and it took them years to get rid of the N95s that they were sitting on. And so I think that's things to just keep in mind as we kind of keep moving through the day and painting the picture of, the causes and the reasons that we end up with the system that we've got at the moment. So Ebola, personal protective equipment, a little bit on H1N1. And we're going to shift a little bit and talk about some drug shortages and the experiences and some stories around that. So, Alan?
Great. As Linda said, I work for the Institute for Safe Medication Practices, which is an independent, nonprofit medication safety organization. And we've been in existence about 25 years, and we also have a national medication error reporting program. So through this program, practitioners report to us on errors, potential errors, near misses that may happen in their workspace. During the last few years, actually during the last decade, we've been getting a lot of errors in due to the drug shortages. We did a survey back in 2010 trying to get a feel for the marketplace. We did one again in 2017, and about 2/3 of the respondents in 2017 said that they were impacted and patient care was impacted due to the drug shortages with medications. There also was other surveys, American Hospital Association, American Society Health System Pharmacist, but some of you might have heard there was this recent survey by the Anesthesia Society, and 98% of the 2,500 respondents said that they are consistently experiencing drug shortages in their practice. So I think from a bigger picture with the medications, I'd like to just talk about a couple things that we actually heard from the first speakers too, focusing on some of those critical care critical medications that have been on shortage, and they've been on shortage for quite a long time, even though there may be dips. We hear from the FDA too, one of them being the electrolytes. We get in a lot of stories. We're talking about potassium chloride, sodium bicarb, magnesium, and these are things that are critical in the hospital setting. The other piece is they're also critical for those patients that need parenteral nutrition. And there's been shortages in rationing and also some compounding that's going on because of different sizes, strengths, concentrations that have led to errors. There's also, we heard with the epinephrine shortage, with the EpiPens, but actually there's been epinephrine shortage also by itself. And epinephrine comes in ampules and vials and different concentrations. And we just had one with the EpiPen, which isn't unusual, that a lot of emergency departments have been using that to treat allergic reactions. We just had a case where a young child came in the emergency department. They didn't have any EpiPens. Physician had to do a ratio strength from an epinephrine vial, and actually the child got 5 times the dose of the medication. Fortunately, they survived. But these are the type of things that we get in that actually affect patients due to the shortages. One of the last things I want to just talk about too that we heard was the opioids. There's a shortage that's been going on. We first wrote about fentanyl shortages back in 2001. And we're still having fentanyl shortages now. And unfortunately, what we're seeing, and although we're not getting into some of the causes, is that there is this promotion, there's the push because of the drug abuse, which is true, but there's also some quota cutbacks. We heard that from the FDA, we heard it from Cleveland Clinic, we heard it from some of the other speakers, that due to the quota cutbacks from the DEA, a lot of these products, these opioid products, the API, the active pharmaceutical ingredient, isn't available. So we get a lot of errors due to that. There are a lot of products, they fluctuate. A hospital may have morphine today and they have hydromorphone tomorrow, and the next day they have fentanyl, and these are medications that are used for surgical procedures, for chronic pain patients, and also for oncology patients. They do have a place in the acute care and also outside the acute care setting, although there is the emphasis on the abuse, which is also very true. So even with that, we just received, with the last error that we got in with, it was an elderly patient, came in through the emergency room with bowel obstruction and received 10 milligrams of morphine IV every 4 hours instead of 2 milligrams. And why was that? Well, because the hospital stocked 2 milligrams per ml vials of morphine, but there was a shortage. So overnight they had to switch to 10 milligrams per ml morphine. The communication didn't get out. The whole vial was given because the nurses were used to administering that whole vial as the 2 milligram dose. And I could go on with other errors with this, but I think the important piece is that there is errors that do occur. We heard a lot with the labor that's put into it, the changes with the IT, but we continually get in many of these reports, and we do try to work with manufacturers and the FDA also. The FDA is doing a good job with the importation, but there also is some issues with the foreign drugs. We heard not having barcoding on them, the labeling. Actually, some of the concentrations are different. And actually, some of them have some foreign labeling on them. So it is something, I mean, they're trying to do whatever they can, but I think we just have to keep in mind that a lot of patient care is being compromised due to some of the errors because of the drug shortages.
Okay, Bonnie?
Well, thank you for this wonderful forum. This is fascinating. So I'm Bonnie Levin. I'm from MedStar Health, probably the most local member of the panel. If anyone gets sick, you'll end up at one of our hospitals. MedStar Georgetown's up the street, MedStar Washington Hospital's the other direction. We're a 10-hospital system. We have 10 retail pharmacies. We have 300 sites of care, including urgent care centers. We are not as large as Cleveland Clinic, but we spend about $250 million on drugs, and a lot of that is the domino effect of moving around product. So I was going to talk about the opioid shortage because I think that if our theme is disaster, the opioid crisis is a disaster affecting public health, and we deal with that every day. And I'll just use that. You could apply it to the IV drug shortage, you could apply it to any other drug shortage, but the steps that we go through in our system are pretty consistent regardless of the story. So I'll just say that from a pharmacy, nursing, provider, ethicist, supply chain, social work, all of these players are critical for managing drug shortages. We have, and I probably didn't even mention informatics and IT. When we have a shortage or a pending shortage, we have to figure out what are the alternatives or the conservation methods. And we typically go to ISMP, we go to University of Utah, ASHP, FDA, and we come up with our strategies, and then after we vet them with all the key players, we have to implement them. And so there are so many technologies now that need to be changed quickly and sequentially so that the providers don't get confused by the dosing for morphine, for example. So we have smart pumps, we have dispensing devices, we have our electronic health records, we have a number of other related software. And so the work involved in doing this and the level of detail that can impact our patients are huge. So as we go through the discussion, I can mention, as it related to a methotrexate shortage we had a while ago, the IV drug, the saline shortage, I think Scott gave some really good information. But we can go back and talk about propofol, we can talk about all the IV, the cardiac drugs, we can pick any of them, but the impact is often the same.
James?
Hi, I'm James Robinson with the Denver Health Paramedic Division, and our EMS agency, Emergency Medical Services Agency, is part of an integrated health system that's part of the Denver Health and Hospital Authority. And the reason I bring that up is that model is unique in some ways, in that we are part of an integrated health system, which actually insulates us from some of these things to a larger degree than many EMS agencies around the country. There's also, I wanted to thank Admiral Vanderwagen and Dr. Yeski for acknowledging EMS as part of the discussion and for the opportunity to represent my discipline here as well. There is really a lack of an evidence base for almost anything related to EMS, so the opportunity to contribute is definitely appreciated. For us, you know, as Bonnie mentioned, the two things we would do are the same. We would look for a suitable alternative when we're faced with medication shortages, and we would also look for ways to, you know, reduce our usage. For us, however, we have a fairly limited formulary in EMS, often dictated by the state's acts allowed, what the state of Colorado will allow us to do in the field. And there are processes to go around that, to circumvent that, but that requires a application for a waiver to the state that, you know, is not something that happens overnight typically. So if you're not aware of how EMS funding happens, it's sort of a hodgepodge across the country, but primarily it's a fee-for-service reimbursement, especially through the CMS stuff, which doesn't pay for our readiness at all. a pay for fee for service. So all of the issues that are associated with our funding model require us to kind of live at our margin all the time. And so we don't really have a lot of surge capacity in terms of supplies and equipment because we're not funded for that. So when we talk about shortages and disaster, we're talking about throwing an additional burden on an already stressed system, like many of the other speakers acknowledged. We're not already sitting pretty. We're already kind of at the margin. So when we look for reasonable alternatives, there are some domain-specific issues for us as well. And our work environment is not one that's amenable to glass vials and glass bottles for IV solutions because we're bumping down the road in the back of an ambulance. And a lot of the time we certainly prefer pre-filled syringes that have a particular dosage in them rather than multi-use patient vials, because drawing out of a multi-use vial with a needle in the back of a moving ambulance is a risk to our providers. So I think when we talk about, one of the more recent examples was the fentanyl shortage that a couple of my co-panelists mentioned. I was notified of that last week, the day of our planning call. And so what we have to do in that case is we have to change our protocols. We have to if there are any retraining that's required, we have to retrain people. We have to make the same adjustments to our electronic medical records that other speakers mentioned. So it's not an easy transition for us.
Okay, great. So you've been hearing a little bit about stories on impact on care and how folks have had to, in the variety of settings that are represented for you here on the panel. But everyone kind of teed up a little bit about the errors that happen because of the shortages and the alternatives that need to be figured out. And there's a healthcare worker shortage potentially, of people not being healthy enough to come to work. And so I'd love for us to dig a little deeper and share with the audience on what are your process? How do you change your protocols? How are you retraining? How are you identifying those alternatives that are out there? Are you working with a committee internally? Are you talking to your suppliers? Are you using the federal government as a source? And I'd love to tease out a little bit more. We'll start with James and we'll just go back in reverse. A little bit more around each of those because you all mentioned that.
So EMS is a delegated practice under a medical director. Typically in our services, an emergency medicine physician, and I think that's the case in many EMS agencies across the country. And so to change our protocols, obviously our medical director needs to be involved in those decisions. And typically those are the he's sort of the person with whom we have the first conversation about, hey, we're experiencing a shortage of X. What are, based on our acts allowed and what he's comfortable with in terms of waiver applications, what are the things that we might use for that? And then if we make a decision, then, we're kind of at the mercy of our suppliers for what does the packaging look like and what are the medication alternatives in terms of multi-dose vials versus pre-filled syringes. If we're making that transition, then we're subject to whatever we can get. And I agree with Alan that we've certainly experienced a higher incidence of medication errors when we've had those situations, not just because of concentration differences, and this may sound really strange, but even the color of the top of the multi-dose vial leads to medication errors because they're used to using one particular type or suspension and a particular manufacturer that has a light green top. We put another med in there in their controlled med box that has the same or similar colored top to it. Obviously that leads to errors as well. So the training might look like anything from, hey, just be aware that we put this new medication in your drug box, and here's what it looks like, and it might be pictures in a PowerPoint, or it could be actually retraining people and showing them how to do it in our deployment garage. I think those are the main points.
Okay, great. Bonnie?
More the same, really. So we're pretty large, and we're, 9,000 nurses and a couple thousand physicians, at 500 pharmacists. So just whatever we decide, once we get to that end, communicating that out is probably our biggest challenge. Okay. So communication is huge. Education on the ground is, one-to-one is near about impossible, but we need to do that. Backing up, I alluded to, once we hear about a shortage, we have to gather as much information as we can, and I mentioned some of the sources. And another really good source is the community. So, all the chief pharmacy officers call each other, and we figure out what are the creative solutions. Then we figure out, can we get that solution? Is it a product that our wholesaler can provide? Because there's this whack-a-mole effect that you mentioned with the saline shortages. If we move from one product to another, eventually that's going to be short, and then it just goes on. And what we find is that we create there's a lot of noise from all of the alerts, and there's providers get really immune to the changes. So that's, again, back to the communication. But so once we decide what we're going to do, then we have to build it in all of the different sources. We need to educate. We need to do all the logistics. So we talked about the impact of supply chain. Our buyers are attached at the hip, essentially. They talk all the time because we're able to move product around, much like Denver. We are an integrated delivery network, and so we do have the luxury of being able to share some product. But ultimately, it comes down to getting the best information, making the decision on how we're going to do it, getting it approved, which is easy. It's just finding the stakeholders to agree, presenting the data, but then it's just on the ground, building it, getting it done, getting it communicated, and then monitoring it to see if we're effective and safe.
Do you also share with other hospital systems or not yet, or only sharing kind of with hospitals within MedStar?
Product?
Yeah.
Typically, we just share within our own hospitals, but we've loaned and borrowed to other local hospitals as needed.
Great. Alan?
Yeah, I think going along with the other two speakers, and probably this morning too with Scott from the Cleveland Clinic, what we try to do, our organization, we do get error reports in, and a lot of times we'll get in that an error may not have happened, but there is something like a near miss due to the shortages. So it is something that, just like James says, we get those in constantly on, there's a shortage, the other manufacturer's vial looks exactly like another drug. It looks exactly, so what we try to do is get that information out. We publish a newsletter every 2 weeks that goes out to every hospital in the United States. So we try to get that information out to the practitioners as soon as possible. And that is something that then they could hopefully use to get that information out. Now with our organization too, we've probably done more. We also do a national alert. We call our national alert, and we have other organizations try to push that out with us. We've probably done more of those in the last few years to try to get the word out on some of these shortages, on some of the concentration changes. So that's something that we know that we've been doing more and more, but relying on the organizations to let us know. The sad part for us too is that we do get a lot of feedback on the amount of resources put into this. We heard from the prior panel too that they have a full-time FTE just looking at this, and that's what we get back to. We have a group called the Medication Safety Officers Society. That's actually a networking group of medication safety officers around the country. We hear from them more and more that the majority of their time is being taken up by drug shortages, not on trying to address some of the other issues that are out there. So those are the type of things that I think we see how tough it is out there, but we try to get some of that information out, but then it's onto the frontline staff, the practitioners and that, to try to communicate this rapidly.
Okay, great. And then for Mike, as a manufacturer, it might be a little bit of a different spin, knowing from your experience during Ebola when you ramped up, only had to ramp back down. Talk a little bit about what you've done since then in protocols and processes that you might have in place, maybe around getting at, what is that true demand, going forward so that you're able to make decisions.
Well, most of our business is making masks for other companies because our masks cost a little more than foreign-made products. We are not successful selling our own brand, so I make masks for other people. And so it's a small group, and it's easy to maintain constant communication with these people. And they've come to trust that we are able to ramp up. We'll work weekends, we'll work nights for our private label customers, but there is a problem with that, and that is that since we make products in the United States, we have to keep our profit margin very low. When we ramp up and run overtime, we don't make any money. So there's a real balancing act there. How much do you ramp up and how much money do you want to lose? And then if we raise our price, even just to cover the overtime, it appears that we are price gouging. So we don't do that. We've never raised a price. So to answer your question, I think of the movie It's a Wonderful Life. Remember the scene where there's a run on the bank and all the George Bailey's customers come into the bank and they want all their money? Well, as we all know, it's not there. They only have a certain amount. So he has this wad of money and everybody says, I want all my money. And it's kind of like that in the pandemic. Everybody, I want this, I want this, I want this. And even with these customers. And so I'm standing here with this stack that's not big enough. So I kind of do what George Bailey did, and I say, okay, I know what you want. What do you really, really need right now? And then that amount goes way down. And then I'm able to respond. And for the same reason it worked in the movie, it works for us because people trusted him. They trusted that if they didn't take all the money out now, they would have some later. And that's the way we work. So it's a lot of communication and a lot of trust. They know that we do what we say, and they know that we're going to do everything we can, and they know we're not going to raise our price.
Great. All right, we're going to wrap up that question then back to you, Steve, and adding more a little around the pediatric perspective since we learned this morning. So 20%? Is that what Dr. Yes said this morning?
Yeah, thank you.
20% of our population?
I mean, the pediatric population is, I think, uniquely affected by this. But before I get to that, to James's point, as these changes occur, it's, first of all, tough to keep up with the changes. And we have a very robust system. We also have a pharmacist who focuses on this, and multiple communications with staff, particularly when a product changes. And sometimes the change is very subtle. It just might look different. And it's amazing how that impacts practice. There's something called look-alike, sound-alike medications. And while we created a list of this long ago and have beat this into the head of our providers, every now and then there's a new one that looks just like the other medication, which if you chose would be really bad for the patient. So getting this information to frontline providers is a great challenge. And there is a bit of the fatigue thing because the notices come out weekly now. In fact, sometimes daily. Secondly, there's a reason why there are first-line drugs. First-line drugs, back in the bad old days, it was just gestalt. I just like to use this medication. Well, today we actually have clinical guidelines and even some evidence, maybe not so great in pediatrics, but evidence about why it is that we use antibiotic A versus antibiotic B. Antibiotic B might work just perfectly well, but first of all, its safety profile is not nearly as good. Higher complications, its efficacy isn't really quite as good for that particular disorder that you're treating. And finally, the cost is 4 times. And in the environment that we're practicing now, we're actually being expected to practice cost-effective medicine. And these drug shortages come along and they throw everything out the window. Pediatrics is uniquely affected by this because maybe not with every single medication we use, pretty much everything is dosed on weight. And most medications, the injectable types, are not really out there in pediatric formulations. They're out there in a generic formulation, so they frequently need to be diluted. And sometimes we'll get another version of epinephrine, but it's a different concentration. And yeah, you can actually probably safely give a child 5 times the dose of epinephrine, but you probably don't want to do that. You also don't want to just, the bigger problem sometimes is overdosing, but the other problem is underdosing. Why is the patient not responding? Oh, the epinephrine dose I'm giving is 1/10 of what it should be to circumvent anaphylaxis, which is a life-threatening disorder. So the impact in pediatrics, both from a supply perspective, the liquid formulations, but also in terms of the dilution issues, is really rather pivotal. And yes, we have seen substantially more medication safety concerns, lots of near misses. We learned from our near misses, but let's just say our safety officer and our chief medical officer have become very busy people because we're constantly talking about this.
Okay. I have one more question for the panel, but I want you guys thinking about questions that you have for the panel to make sure we've got enough time for a robust discussion. And this should go, I think, fairly quickly. And there's 2 mics, one in each aisle. And I was asked to remind folks, even though we've all been getting to know each other with the networking, to state your name and the entity that you're with and speak very closely to the mic so they can get captured and recorded. And this, we are being webcast as well so that everybody can hear. So as you think of those questions, I invite you to start standing up in the aisles. And then my question for the panel before we officially open it up for Q&A is, talk a little bit about, everyone's talked about communications, everyone's talked about education and working through their protocols to institute new things as alternatives are coming because of the shortage. Would love to know, are you getting all the right information in a timely manner? And I'd love to hear an example of, yes, we did in this case, and it was this information, and an example of what would you love to have that you're not getting as quickly or as in a more understandable manner, whether it's from suppliers, whether it's from the government, whether it's from your colleagues. You know, what kind of information is missing and not as timely? Who should I start with? Steve.
Well, I think as was alluded to in the prior panel, there's sometimes a gap between when the FDA is made aware of something and when the frontline providers in the emergency department of Leary Children's are searching for that medication. And yeah, we have, again, a robust system which makes us aware. You know, we've gotten so worried about this that we actually probably over-communicate the problem. So I'm constantly hearing about medication shortages that actually never touch me, but we're made aware of the problem. The other thing that actually creates a problem, which is relevant, is that when we decide that there's a real shortage, we limit the use of the medication or the product to key scenarios and or on approval only. Well, the approval process takes time. You got to call somebody, at 10 o'clock at night, it could take 25 to 30 minutes to find that person who says, well, of course you should be using this. Why are you asking me? It's like, well, it's because I have to, because the pharmacy won't give it to me. So it's understanding the actual impact. It's like predicting the path of the storm. Nobody really knows, but you have to be prepared. And the preparedness piece causes its own havoc.
Mike?
During Ebola, or actually before Ebola, well, let me go back a little bit to H1N1. Before H1N1, we were a brand new company, and we contacted a local hospital system called Texas Health Resources. It's one of the bigger systems in Texas. We have 25 hospitals, and we said, we think there's going to be a problem with the mask supply and a shortage. We'd like to talk to you about American-made masks. We showed them our factory. They said, that's all well and good, but we don't know if your masks are any good. We're interested in your story. We're interested in supply. We don't know if your masks are any good, so try them out. Let us try them out. Well, it's a weird coincidence. During the evaluation, H1N1 hit. So our prediction came true. So they were the system that stayed with us, by the way. And then, before Ebola, when Ebola was announced, I called them up and I had a lot of credibility at this point. I called him up and said, hey, you know, Dallas-Fort Worth is a major metropolitan area. It's possible that you could have the first Ebola case. Not likely, but why don't you come over? Communication. I said, why don't you guys come over and let's talk about it and plan and see what you're going to need and all that. Well, as luck would have it again, they were the first Ebola, or first hospital to get an Ebola patient. And now they say, don't predict anything else. They don't ask me to say anything. But so to answer your question, we just communicated with our customers. And you know, I've heard several people say that the manufacturers aren't very forthcoming. I don't get that, because in my business, we are, and we want to know what's going on. And I've got a phrase that's, I say bad news doesn't get better with age. People need to know it. They need to know it as quickly as possible. So talk to my customers, whether they're hospitals. I also, I'd like to say that this partnership that we have with the manufacturers and the government, in the case of me, I worked with Robin Robinson at BARDA, and Robin graciously went and gave a talk in Houston to a bunch of hospital systems, communicated with them about the issues of the mask supply and stuff. Well, MD Anderson listened to him and said, hey, this is real, and we're going to take care of it. So MD Anderson also went with this system. So I communicate with those people on always, but during any kind of emergency, it's every day.
Alan, are you getting good information, and what are you missing?
I'd like to just say one thing about the global issue, that's with the communication, and some things that I'd like to see come out of this too. With the it is a global issue, and even with the FDA, with importation, with other countries, with manufacturers from the other countries, hopefully we have this as an opportunity. The FDA just had a meeting with some other country, quote, FDAs from the European and other countries and that too, and to maybe make more medications in vials and not have the ampules, maybe get some common labeling in concentrations, maybe get some common labeling in warnings. There's ampules overseas that are neuromuscular blocking agents that don't have any warning. You wouldn't have no idea that you could mix them up. I mean, there's been deaths where they're used as a diluent. So I think just from the standpoint of what I'd like to see, at least some of that come out of this also, because it's a global, and we're going to be doing a lot more importation and that around the country, around the world.
Well, I'll just add that one piece of information that would be very helpful in managing through a shortage is the duration of the shortage. Now, you know, my crystal ball stopped working when I was a teenager, but if we had that, it would be a whole lot easier, because your strategies that you plan are different if it's, you know, a couple days or a week versus months. So again, transparency to the FDA, that 53% of we don't know why it happened, and I understand the FDA does have information, but if it's a manufacturing problem versus API versus, you know, some other issue, that would help us do better prediction and management.
And I assume that filters into then how you'd be able to retrain people for how, versus 2 days versus 2 weeks versus 2 months, and then if there's alternatives, you know, are you looking at a longer term and that type of stuff? And James?
Agreed on all those things, and I think the more notification, the better. The earlier notification, the better for those types of planning considerations. And the transience is certainly an enemy too, because the flip-flopping back and forth is personnel and time intensive. And once we, you know, for us, when we transition from one medication to another, we have to change that out in 40 ambulances. So it's not like we can just go to the cabinet and get a different medication out. We have to change that out across our entire fleet and all of their medication boxes, the kits in the ambulances as well. So it's definitely has some personnel, time, and cost associated with it as well. And, you know, tag on to Dr. Krug's point about pediatrics, and the concentration and weight-based systems, we've adopted a system that's based on our specific concentration of medications to reduce errors in pediatric patients, because we don't see a lot of them. So they're the kind of high-risk, low-frequency thing for us. And in an attempt to sort of standardize that practice to improve the safety and the better care of pediatric patients, the changes in concentration basically disrupt that entire system, which is based on, a specific concentration that we use in our agency. So for us, that creates big problems in the care of pediatric patients.
Okay, great. Audience, don't be shy. We have about 25, 30 minutes for questions. There was lines for the first panel. Don't leave us hanging here on the second panel, or I will keep talking, which you don't want me to do. So, great.
I never want to leave anybody hanging.
Thank you. Thank you.
Karen Remley from the de Beaumont Foundation. And what hit me listening to everybody is I started medical school in the late 1970s and residency in the 1980s, and we had glass bottles, and we had multi-vial, doses, and we had 3 different doses of epi in the ER, and we documented all of these problems. And To Err as Human came out how long ago? And I'm listening to all of you thinking, these are all the reasons why we changed to what we changed to. And there was a fundamental shift in medicine to say, how do we make sure that medication delivery is the right dose to the right person at the right time? And because of these shortages, we are really undoing what is now close to 30 years of work. And I think one of the things that hit me, and I say this not from de Beaumont or from being a practitioner or public health person, but how do we communicate that to the general public so that we get things to happen? Because if you think about it, To Err as Human made a right turn, right? In our country, people woke up and said, okay, lots of bad things are happening in hospitals every day. We need to think about how to fix them. You are telling us anecdotally right now of what's going on in your institutions. That's going on in every institution in the country. And hopefully, most of them are near misses and people learn from them. But we know how to prevent those near misses, and we're not doing that. And so I guess in some ways, I'm feeling like the healthcare systems are doing such a good job of trying to be facile and nimble and fix all these problems as they occur. And what we really maybe need to do is step back and say, how do we prevent them, the public health approach? How do we prevent them from occurring at all? And that may be, as we talk tomorrow about potential solutions and responses, how do we think about collectively how we raise that information in a way that makes our stakeholders, decision makers, and general public understand how important it is? Because I think we're talking to each other in this room in some ways.
Any comments? I see heads nodding, and yes, that you.
Well, yeah, I think that's a great point, and engaging the public in discussions about anything to do with care seems to be challenging from my perspective and my experience. And I think the public really trusts in the institutions of medicine in our country, and I don't think they're discriminating consumers. I think that's well documented. And so that leaves all of us that are providing the care with a pretty big burden of, upholding the trust that people put in us every day to give them the best care. And I think that's certainly a challenge, and I hope that gets fleshed out further in our discussions about how do we engage the public in the discussions.
Okay. Steve, you had a comment?
Karen, I couldn't agree with you more. The shortages have disrupted decades of work on patient safety and also decades of work on clinical guidelines that are based upon evidence, because we did all this work, but this drug's no longer available. And that's got far-reaching impacts. And what I don't think we've done well enough with this, I think we're doing our best to get it to the frontline folks, at least in their institution. I'm not sure it's making its way to the community, however, because we see lots of patients who are sent to us by, I think, pretty bright providers who apparently aren't aware that there's a problem. I don't think we've done a very good job in informing the public and our patients I think when something really rare and desperate for patients with specialized problems isn't available, I think we do a good job of reaching out to those families and letting them know, but across the board, I don't think we're doing that. And the solution has to be one where we work together towards finding the answer here, including the public.
Okay. Alan, you have one comment too?
I think when we had the last shortages years ago, the public was actively involved because there was a lot of chemotherapy agents that were on shortage. It was all over the news, it was all over the newspapers, there was rationing, people were being stopped in the middle of their care, and I think sometimes, unfortunately, that's what you need, is that what reaches. A lot of the shortages we're having now are just as serious, but we're handling them. They're not out in that public. There might be some out there with surgeries canceled because of some of that, but a lot of what's happening now, and we've learned, and maybe that's a good thing, I mean, we've learned to work together a lot closer, have these huddles, have these meetings, communicate a lot better and handle it. But with the public, I do have to say, if those that remember from the last shortages, public was actively involved. But it was because it was a different category of drugs that were directly affecting them.
I would just say at the bedside, involving the patient and their family is critical because they double check us. And so shared responsibility, I think, is becoming more common. And in this day and age where it changes minute to minute, involving the patient in their care is even more crucial.
Okay, great. We're going to go back and forth. So, Laura?
Laura Wolf, HHS Asper. One of the notable comments is how much time is taken by the provider to either work out whether or not drugs can be given, or the example with a saline syringe push, how much time is taken on nursing staff. Are there opportunities for solving that or taking away some of that burden by looking to coalitions or professional associations to provide more guidance than is being provided now? Or are these treatment decisions so unique that this really has to be taken on by an FTE at that facility or the planning staff at that facility?
I'll start and say that some of these scenarios turn on a dime. So we look to the literature to see what's out there, and we bank on people's training to have done it before to look back. I was thinking about the IV saline shortage. We were looking to old solutions, and some of the large volumes, when we ran out of pumps, some of the nurses remembered from 20 and 30 years ago, gravity flow, and the newer nurses had no idea. So some of it is muscle memory. Some of it, you just have to say, this is changing right now, here's what you do. You try to accommodate with a dosing chart, for example. And we try to accommodate with building rules and alerts in the EMR so that you make the right thing to do, the easy thing to do, but it's just more and more noise.
And I think there are a lot of professional organizations, some of them are here on the panel, that I think have large constituencies of varying types of healthcare providers that I think offer a lot of guidance. I think the FDA is also a good partner in this, the CDC from time to time. In the end, though, it's a local solution, because this is what you've got, this is the patient population that you're serving, and then how are you going to essentially ration the product so that it maximizes its impact. Again, it's fundamental disaster thinking, but this is happening on a day-to-day basis, which is something we're not really used to doing. There are also ethical issues involved as well. I know that we have an ethicist here today, because how do you make that decision about which patient's going to get the last 5 doses of this medication, and how are you going to say no to those other patients? I fortunately don't have to face that fundamental question, but again, when things are in low supply, it just slows things down. And if you're an EMS provider, you're working in an emergency department or an ICU, you don't have time to slow down, because if it's not that patient that's in dire straits, it's the patient next to them. So it's added a lot of, it's really pushed us back to a day when we weren't as nearly as efficient because we didn't think we needed to be efficient. So I think there's opportunity to share experiences and best practices, and I think that's ongoing, but maybe we can amp that up, because I don't think this problem is going away anytime soon.
If I can add to that real quick on your, I think the healthcare coalitions actually serve as a great venue to have some of these conversations. And then they also serve to kind of create an environment where there's some situational awareness, and we've, in our regional healthcare coalition, which is 10 counties around the Denver metro area, we've actually had competing hospital systems sharing products, because there's awareness that this, children's hospital needs this, and everyone rallies to the cause, and having some awareness of issues, I think, and some common operating picture definitely helps. So I hope that those conversations continue, and I hope that becomes more the norm across the healthcare coalitions.
We're back over to here, Sarah.
Hi, Sarah Rozak with the National Association of Chain Drugstores. So I wanted to piggyback on some of the other questions asked already, and think about patients and how to communicate with them. And I'm wondering, in disasters, if you all partner with other organizations to ensure a consistent, clear message is provided on what kind of shortages are happening right now, and how to address that. I heard you mention healthcare coalitions. Maybe that's one way to do it, and just opportunities to connect with local and state health departments, maybe community pharmacies, other stakeholders that also would probably be sharing a similar message as your organizations as well.
No, I think the partnering with public health is, I think, essential if we're going to power our way through this, because we can assist in delivering a key message to the public, because just go to your favorite social media provider and you'll find information that actually isn't quite true, or you'll find information that's alarming. So again, collectively as a nation, through healthcare coalitions, through strategic partnerships, I think we can better inform the public, both during an event and actually, frankly, even before and between events, because people are always going to find information that's going to terrify them, and that's unfortunately going to be, again, part of our environment going forward. So I think that, I do some work for the American Academy of Pediatrics, and we've really enjoyed our partnership with the FDA, with the CDC, with ASPR, with FEMA, and a lot of that's just, some of that's brainstorming and coming up with the, how can we collectively do better for kids, but some of that is just getting out there together and leveraging information that's sensible to the public.
The Secure Mask Supply Association has 4 competitors. We're competitors in one sense. We make masks and we want people to buy our masks, but we're partners in another sense. We're partners in national security. And it's pretty loose and pretty casual, but we communicate during, anytime there's an announcement of Ebola or something that looks like it's going to be bad, or even a bad flu. If I can't help somebody, I'm going to call one of my competitors. So we try to, like I said, even though we're competitors, we try to communicate with each other where it's important. Now, we don't share pricing and we don't do that sort of stuff, but...
I think the transience of the shortages make the public messaging problematic too, because you don't want to wear people out with communication every other day as these things change. And I think we're better at the crisis communication when you're in the middle of something than we are at the day-to-day, more routine situations. And frankly, I think the public's attention is better during the crisis than it is during the day-to-day as well.
Good point. Okay, thank you. We're back over here.
Sherry Fink, I'm a journalist, and I wanted to sort of, my question is piggybacking off of that point, and also the comment about we're handling it, and this difference you pointed out between when there were certain types of shortages that got a lot of media coverage and others that get less. And I guess I just wanted to say it's an interesting problem, this idea of putting too much information out there, but this other instinct to try to not make the public afraid, I think is maybe, I'm wondering if maybe it's not so helpful when it, even though you're handling it, it's still having these effects such as, you know, errors and having to ration or choose certain less suitable drugs, things that have ethical implications that you might want more public input on, and then of course the things you mentioned that there's a possibility for legislative action. I think in the previous panel discussed possibly new mandates on manufacturers, et cetera. So I guess, would you consider that this is a role for wanting to inform the public, wanting, you know, for both ethical reasons as well as if you want them to care about an issue that you know is impacting them, what other way than to share that information?
I think the public, I think transparency is better, for sure. The questions that I find interesting, though, and when we're talking about shortages like saline, is even from my own organization, my peers and my partners, the question comes up, what's the big deal about salt water? Why is salt water such a difficult thing to produce? You know, I can make it in my kitchen. They don't understand all the process pieces that go into that. And I think the public would have a similar reaction if you were to ask generally, so what? You know, what's the burning platform that I need to be concerned about? There's a shortage of salt water. So I think the public messaging is important for sure, but you have to provide also some baseline understanding of, you know, frame the problem for the public, and then have the continued conversations.
Yeah, when I had mentioned before too, with the we're handling it better with the chemotherapy and that too, is that we constantly get called, our organization, by reporters and by the press. And when it comes to errors or things with drug shortages, I mean, we get calls now and they want to know who died and can I talk to their mother, and the information we get is confidential. We don't share it with anybody.
Don't you think those mothers want their stories out?
But that's the type of thing that oftentimes, sometimes maybe the media, the press could do a better job of not just looking for that story. Because as I said before, with the chemotherapy, when there was all those errors, there was a lot of patients that were coming out and basically saying, here's my loved ones and that too. So I agree with the transparency. I agree that that is, but I know with us too, sometimes it's hard we can't give out too much information on something that they'd want, but that's the story. It's not the story that, oh, maybe somebody just got, like, you know, a near miss or this is that.
Anyone else? Great points. Oops, I'm sorry.
To your point, educating the public, yes, we run the risk of frightening them. And you and I were talking at the break about, with the IV shortage, patients were worried that if they needed a bag of saline and they showed up at the emergency room, it might not be there. So they may call 5 ERs, you know, and so maybe that's good patient engagement, I'm not sure. But the education piece, I think, can create a drumbeat to help with the legislative process. So, you know, I think that if people know that there are possible solutions that maybe we'll come up with tomorrow with potential regulatory or legislative assistance, having the public aware would be very helpful.
Yeah,
Or
I was
even
gonna say the same thing.
incentives to our wonderful mask manufacturers, like should there be some programs that could help support those choices?
Let me say, first of all, I've been involved with the media a lot over the last several years. It seems like every time there's a flu or something, my phone rings. I would have never thought, when I was younger, I would have never thought I'd be on CNN twice, but I have been. It's just crazy. But let me say this. All the stories were accurate. All the stories were helpful. And there was no fake news. It was very helpful. I thank the media for helping us get the word out that the story they wanted was, hey, you're ramping up. You're making lots of masks, and that's the story. And I said, no, the story is the mask supply is insecure. And they would tell that story over and over and over. If you Google Prestige Ameritech and Mike Bowen, you're going to see a dozen news stories. And they were all accurate, and they all did a really good job. Thank you, the media.
All right, we've got two last questions, but I know we had a great conversation, I think, that draws a lot with communications and educating and using the right info and getting it out in a way that doesn't panic people, but gives them context. Because most people in the public don't understand all the medical terms, and why the salt water, is a great example, is important, and why it isn't as easy to make as it is you think it is in your kitchen. We got two last questions, and I think we actually will end on time. So our last two questions, yes.
Hi, I'm Julie Swan at North Carolina State University. So I'm an academic who's been specializing in supply chains and healthcare. So I want to ask a little bit about data and information sharing, particularly from those of you who are on the provider side of things. What we heard this morning about the shortage definition was really a national level definition, which is critically important, of course. But from supply chains, we also know that shortages can be much worse locally because of having many stocking locations with variability and those kinds of things. So the first part of my question is, are you doing things to try to capture what kind of shortages you're experiencing locally? And if you are, with whom are you sharing that? Is it being shared within your hospital system to other peer institutions, or are you sharing it back up to the distributor level? And then the third part of it is, if you're not collecting that data now, what would it take to enable that for the future?
So for our providers, are you guys collecting that info?
I can start on that because it's really an on-the-ground question. So when we have a inkling about a shortage, which usually comes from the manufacturer, from the distributors, the first thing we do is inventory all of our locations. So we have a buyer who goes to the shelf, actually counts the product. We aggregate that data, and that's our starting point. We then see what's coming, going back to the distributor, so that we can get a sense of that prediction. But that's our first line of data. Our second line of data is to assess who is using that drug. So what specialty, I think someone alluded to that before, what location, and then we can begin to look at what the alternatives would be, based on either conservation or finding alternatives.
Yeah, our process is strangely identical.
Only so many ways to do this, I think.
And the forecasting part is important because that's when we get information out to the providers about limitations for utilization, whether it's for specific patient populations or for specific indications or locations. Again, we are probably overly cautious, which is, I think, the right approach. The last thing you want to do is have the patient who needs the drug, who can't get the drug because I just used the drug for a patient who just didn't really need it as much. We are tracking it. I'm not really sure who we're sharing the information with. I know that there's some sharing within the Children's Hospital Association, and I know that we've got folks that are attached to the ISMP, but I honestly don't know. I don't know if the federal government is aware of our experience.
Great point.
I don't think we're very good about sharing that information. Our process is also similar. And as part of integrated health system, we usually will query our own usage data to figure out how often are we giving this particular medication, and if we could give up our supply to help. For example, magnesium sulfate, we gave up our supply so that they could have it in labor and delivery and within the institution, because we didn't use it very often in the field, because it's a second or third line drug for us, and it's the first line drug for them. So we use those types of decision-making processes, but I don't think we're very good about sharing the information when we get that there is going to be a shortage with our peers and other EMS agencies.
Great question. And then Karen, you get to be our
That was
first and last question.
So I'll go back to what I talked about when we talked about to err is human. One of the big things that came out was every day it's like an aircraft crashes every day, and an aircraft crashed every day in the United States. Will we do something? And it motivated people at AHRQ. We got quality metrics. We measured never events, and we put in places and programs to improve that. And I've spent the morning listening to everybody tell me they're altering their standard of care regularly because of medication shortages, but we're not really keeping track of it. And to me, going back to what Sherry was talking about, we elevated it up to, this is about, are we doing the very best we can for every patient every day? How do we measure that and then show the public and stakeholders this is a real problem to the health and well-being of people in our country, and how do we think about that? And I'm looking at Craig, because if we can get that awareness for the everyday minimal altered standard of care, it helps out a lot more during that major disaster. But I don't know, and I'm listening to two chief pharmacists from two very large systems talking about near misses, and you're talking about a children's hospital. There are 140 children's hospitals in our country that are going through this every day. I would hazard and would not want to guess how many near misses are occurring, but if we can think about how to describe that, quantify that, and measure that, that becomes something you can talk to the public about, why it's important to look at this as critical infrastructure. Beyond, that we'll just, don't worry, we'll fix the problem behind the scenes and it'll all end up okay at the bedside, which I just don't know whether that's true or not. That's what I think one of the things we should be thinking about over the next couple of days is how we talk about that and quantify it.
That's probably a great point to end on. And then I want you to join me. One, you were a great audience with questions, so thank you. Please join me in thanking our wonderful panel. And then do I dismiss for lunch, or are you coming back up? I'm dismissing. Do we have any housekeeping that we need to let people know? All right. Okay.
And Karen, thanks for that. I mean, are we using crisis standards of care every day becomes the question. Dan Hanfling and John Hick, where are you? And, Kevin raised that today about crisis standards of care. Well, maybe we're doing that more on a daily basis than what we'd like. But lunch, essentially, there is a cafeteria in the basement here in the building, and you're welcome to go down there. There is a list of some nearby restaurants. It's available out at the desk. So we invite you to go to lunch. Presenters and planning committee, there is a members room, and there will be a light lunch there for that group of people as well. So if you're presenters or you're in the planning group, there is light lunch available in the members room, which is down here and to the left. If you have a question, ask the staff. They'll get you there. Okay, go to lunch. Please be back here at 1:30. I was wrong. It was supposed to be at 11, so we cut you guys short by 15, and I'm sorry for that. I apologize. But 1:30 is when we'll start again. Thank you.